All right, class, back. This is take two. I've recorded this lecture already once, but the audio looped, and all you heard was just kind of the looping audio of me talking over and over again, so it was pretty unlistenable. So we'll try again. What are we going to do today? Let's review the exam real quick, and then we'll talk about some pulmonary physiology. Okay. So, moving on with the exam. Number one, how glycogen breakdown occurs quickly. And if we're talking about this one overall, what we're going to be talking about is our alpha 1,6 bonds and the fact that they create a lot of end units through their branching. So the correct answer there was A. Two, and this is one that we had some questions on via email, and there was a mistake here because the correct answer that I was looking for was A, that glucose binding to the cell surface signals translocation of the GLUT4 transporters. Remember, glucose doesn't bind, the insulin is what bind. However, there's also another incorrect answer in here, that insulin-stimulated activation of AMPK is not a thing. Remember, AMPK is activated by high concentrations of AMP, not necessarily by insulin. So if you had chosen A or B, or A or D for that one, either of those two questions right there, rest assured that you will get the answer to that one marked correctly when the grades are input, hopefully by the end of Monday. Okay, very smart dietitian. For Gerald, remember, if they're looking at 80 or 90 grams for 100 kilogram human, remember we have 0.8 or 0.9 for non-athletes right there, but an adult. Lactate threshold is our 1 millimole above resting value right there, not our just reaching 1 millimole. Remember, it has to be above the resting value. Alanine glucose cycle refers to amino acids being used for ATP creation while removing that ammonium. Okay, 6 was a little bit of a challenging one. What we're looking for here is we're looking for carbohydrate use. But if you look, our y-axis on this figure right here is fat. So if we want to get carbohydrate use, assuming that fat and carbohydrate are the only energy sources for exercise, all we would do is take 100, subtract the fat percentage from it, and that would give you the carbohydrate percentage. So let's move down to our figure and let's draw a couple lines. This will help us. We know we're going at 50% of our max overall. Okay, so now we draw our two horizontals across. If we look at our untrained state, we know we're about 20%. If we look at our trained state, we're about 50%. So, trained fat equals 50%. CHO equals the other 50%. Untrained fat equals 20%. CHO equals 80%. So if we're going from untrained to a trained state, we know we're going to go from 80 to 50%. So the correct answer there would be C. Okay, hydrogen ions being transferred from the inner mitochondrial matrix to the intermembrane space due to the action of one NADH molecule, which has been created during glycolysis. So remember, that's in the cytosol, so it has to get transferred into the mitochondria through a shuttle. In this case, we're using the glycerol 3-phosphate. Remember, NADH through G3P equals FADH2. Okay, plus one other FADH2. So in effect, what we're looking at is 2 times FADH2. And how many hydrogen ions do a FADH2 move from inside the mitochondria to that intermitochondrial space? And the answer there is we have to think about our different complexes of the electron transport chain. 1, 2, 3, 4, and 5. We know with FADH2 they are skipping complex 1 and donating their electrons at complex 2. We know there's no movement of hydrogen ions at complex 2. There are 4 hydrogen ions that move through complex 3 and 2 hydrogen ions that move through complex 4. And remember, those are going to then move back through complex 5 to create our ATP. So overall, we know that there's 6 hydrogen ions per FADH2. So if we have two FADH2s, because one of them was coming through that shuttle, 6 hydrogen ions from the first one, 6 hydrogens from the second one, that's going to give us a total of 12. Another one that people have questions on every semester here is number 8, looking at me as a mad scientist counting ATP production from fat metabolism. In my strange experiment, I removed the liver of a mouse. The liver is no longer in the mouse after this removal. Okay. After that, I'm going to quantify the number of ATP that were generated from one triglyceride composed of a glycerol and 3 18-carbon fatty acids. How many ATPs? Well, we know in a normal whole person, we're going to get about 460 ATP from this molecule. Okay. But 19 of those are coming from that glycerol backbone. Okay. And if 19 are coming from that glycerol backbone, that occurs in the liver. In my experiment, I removed the liver of the mouse. Therefore, we're going to have 19 less ATP created. So the correct answer there is 441. Okay, when I participate in aerobic training, I can expect the following cardiovascular adaptations. Definitely increased plasma volume and overall increase in blood volume. Yes. Increased stroke volume at submaximal exercise. Yes. Am I going to have an increased heart rate? No. So the correct answer there is going to be A and B. No C. As my exercise intensity increases, carbohydrate is going to go up and fat is going to go down. Increase and decrease. One glucose molecule will result in 2 rotations of the citric acid cycle and 6 ATP because we know we have 3 per round. And if we start with 6 carbons, okay, we start with 6 carbons in our glucose molecule, then we split it into 2 3-carbon pyruvates, and then through pyruvate decarboxylation, we end up with 2 2-carbon acetyl-CoAs. Each one of those can spin that Krebs cycle 1 time, and through each cycle of the Krebs cycle, we know we get 3 NADHs. So there we go. Correct answer 2 and 6. And the process we just talked about that prepares those carbon molecules for entry is our pyruvate decarboxylation. Okay, a little fill in the blank here. During phase 2 of the transport of free fatty acids into the mitochondria, ATP and CoA are added to the free fatty acid to form acyl-CoA. If this molecule is less than 12 carbons, it will diffuse directly into the mitochondria. However, if it's greater than 12 carbons, it would need to be combined with carnitine before it's able to pass through the membrane with the help of transferase, acyl transferase. Once inside the cell, the carnitine is removed and circulated back out of the cell, while the acyl-CoA can continue on to beta oxidation. If you misspelled anything in here, I will be checking these one by one just to make sure that it's not just you put a space in the wrong place or capitalize something that's not supposed to be capitalized to make sure that you get credit. I'm not too worried about spelling here. We'll make sure that you get credit if you put the right answer in. Okay, last one, 20. Which of the following in regards to protein intake would inhibit rates of muscle protein synthesis? We know that answer right there is 75% of protein intake 1 hour before sleeping. We know that if you have 75%, almost all of your protein right before bed, that's not going to be a balanced distribution of your protein intake. So that's going to be the one that would inhibit your rate of muscle protein synthesis overall. All the rest of those are related to good protein synthesis. I wanted to just keep today's review to the multiple choice. I'll be reviewing some of the, or all of the short answers on Mondays. I wanted to make sure we had enough time for our lecture today and get some new information out there as well. So stay tuned. If you will not see your grade updated until later in the day on Monday. But if you have any questions after that point, feel free to get back in touch. Okay, so let's move on to a little bit of our pulmonary physiology. It makes sense that we're moving on to this topic right now because we ended one of the last lectures before break talking about VO2 max and the 3 components of VO2 max. Number 1, oxygen uptake. Number 2, oxygen transport. And number 3, oxygen utilization. Okay? And we generally have only studied kind of function number 3. We talked a little bit about angiogenesis, or the ability to produce more capillaries with our aerobic training, but for the most part, we've only really been talking about oxygen utilization, where that happens at the end of the electron transport chain. Oxygen is our final electron acceptor, and therefore most of the changes we've been talking about to this point have been due to that. Now we're going to move into how that oxygen gets there in the first place. Okay, and it all starts with the ideal gas law. Make sure I got my notes. And I know a lot of people are having flashbacks to chemistry right now, but if we think about the ideal gas law, it's PV equals nRT. What does that mean? Pressure of a gas multiplied by the volume of that gas is going to be equal to the number of moles times the universal gas constant, 8.314 joules per Kelvin per mole, times the temperature. But let's solve this equation for pressure. Pressure is equal to nRT over volume. Okay? And we want to now apply that to the chest cavity when we're talking about inspiration and expiration. The movement of air in and the movement of air out of the body. Okay? So let's start right over here with our inspiration. At sea level, we have about 760 millimeters of mercury of pressure. That's the column of air sitting above your head that's going to be pushing that air into your lungs. Okay? When you breathe in, your intercostal muscles are going to pull your ribs away from your spine. Your diaphragm is going to contract, pulling that diaphragm down away from your lungs. And what's going to happen? If we think about our equation here, the number of moles isn't changing. The universal gas constant definitely not changing, and the temperature is not changing. Is the volume changing? Absolutely. When we move all of those things away from the midline, that kind of space within your chest cavity gets bigger. So the volume is going to go up. If we are dividing by a larger denominator, what's that going to do to our other side of the equation? Well, it's going to make that pressure get really, really small. So if we have a small pressure, that means the pressure inside the lungs is now going to be 757. Based on our simple pressure diffusion, we know that now that air is going to be able to move directly into the lungs. And that's great, okay? And if we think about this, this makes sense, because when you breathe, you do not have to suck air like you're sucking it through a straw. You do not have to do that. The reason you don't have to suck air into your lungs is because there's lower pressure in there. And if there's lower pressure, the air is going to move in there on its own. The opposite happens when we're dealing with expiration, okay? Here's our diaphragm relaxing. When it relaxes, that muscle is going to move up towards the midline, okay? Our intercostal muscles are also going to relax. If we go back to our equation over here once again, nRT not going to change. Our volume is going to now be tiny. If we're dividing by a smaller number over here, what's that going to do? It's going to make our pressure bigger. And you can see that right here in our 763. The pressure outside is still 760. So now our pressure gradient has changed. Whereas with inspiration, our pressure was lower on the inside of the lungs. Now it's lower on the outside. So guess what? Air is now going to move out of the body. So this little kind of exercise just shows you how air is going to get into the lungs in the first place. But if we're talking about air moving into the lungs, we got to get a little bit more specific, because there's different areas of the lungs, and those relate to the use of this oxygen overall. So pulmonary ventilation is the amount of air that basically passes by your mouth in general. And this can be broken down by multiplying our breathing frequency times your tidal volume is going to give you your pulmonary ventilation. For most people, a nice resting value, your breathing frequency at rest, is going to be about 12 breaths per minute. And our tidal volume is going to be about half a liter per breath. So every breath you take in would fill about half of a 1 liter bottle. Okay? If we multiply those two out, we see that our breaths cancel out, and overall we're going to get about 6 liters of air moving past your mouth into your body per minute. Now, alveolar ventilation is a little bit different. That has to do with the air that's specifically reaching the small little air sacs at the bottom of your lungs. And alveolar ventilation is not the same thing as pulmonary ventilation. Alveolar ventilation is AV equals pulmonary ventilation minus your anatomical dead space. And we'll get into that in a minute right here. If we wanted to define this with a nice little sentence, we'd say that this is the portion of air that is exchanged in the alveoli. And this is important. This is where gas exchange once again with the blood takes place. Which is important. Okay? And then if we wanted to define our anatomical dead space, we'd say part of airway where no gas exchange occurs. So, if we have our little picture right down here, how would this be different? Our anatomical dead space is the same thing as our conducting system. Basically, that's just a method for us to get air from the environment to our alveoli, or to where that exchange between the blood and our kind of holding tank can occur. If we want to talk about pulmonary ventilation, that's going to be right here. Pulmonary ventilation is that air moving all the way in, all the way down to the alveoli and back up. Okay? Then if we think about that's our AV. Then maybe we think about, not AV. That's our pulmonary ventilation. Then our alveolar ventilation is just right here. That's us moving into and out of the alveoli. Okay? Then overall, if we think about anatomical dead space, that's air moving in and air moving out, just for that conducting system right there. Overall, the cross-sectional area, don't let this picture over here fool you. If you look at this, and I'm kind of outlining it right here, we look at that, and that seems like it's got some pretty big structures in comparison to these tiny little alveoli right here. However, if you were to chop those up and kind of lay them flat, the cross-sectional area of them is very small. Okay, so the cross-sectional area of our conducting system overall is about 150 mLs per breath, whereas our exchange surface has about 350 mLs per breath. So even though it looks a little bit smaller in the picture, we have a little bit more space. And if I was to define this a little bit better, I wouldn't necessarily cross-sectional area, I'd say volume. How much air can they hold per breath? And if we fill all of our anatomical dead space, we only get about 150 mLs. But if we fill all of our alveoli, we're going to get a much bigger volume. So the question is, how is this influenced now by our different breathing rates? So let's take our example from before. 6,000 mLs per minute of air. If our breathing rate is 12 breaths per minute, okay, and our tidal volume is that 500 mLs per breath, this times this equals our 6,000, okay? And we know that if we wanted to figure out dead space, it's the same thing because we have to multiply it by the number of breaths. So it's 150 mLs per breath times 12 breaths per minute. And what that would give you is about 1,800 mLs per minute. So if we take our 6,000 and subtract our 1,800, That'll give us our alveolar ventilation in this example, and that's about 4,200 mLs per minute. That's how much air you are moving into and out of your alveoli when you're breathing in this manner. If we keep our pulmonary ventilation the same, but we increase or decrease our breathing rate to 6 breaths per minute, well, then we're going to be taking deeper breaths. We're having a larger tidal volume. Bigger breath now. Let's double it. Okay, so we're taking nice deep breaths, half as many breaths per minute. What does this do to our overall dead space? Well, 150, not 120. Not 12 breaths per minute, now 6 breaths per minute. That's going to only equal 900. Now, 6,000 minus 900 equals 5,100 mLs per minute. So you can see, taking slower, deeper breaths, even though the amount of air moving past your mouth is the same in both of these examples, you're going to get more air to your alveoli in this circumstance. And the example I always give for this is, think of when you're taking nice, slow, deep breaths before you hold your breath underwater. That's going to result in getting a lot of air to your exchange surfaces. Hopefully, the goal there is to get a lot of oxygen then exchanged with your blood so you can hold your breath for a little bit longer. Let's go on the other side, though. What happens if we up our breathing rate to 40 breaths per minute, but we're taking super shallow breaths? So this is, you've probably seen that with somebody hyperventilating before. Okay? If we take our 40 breaths per minute, multiply it by 150 mLs. Let me stop that. You're going to get the same 6,000 mLs per minute. Right like that. Okay? If we look at our dead space, 150 mLs per breath, that doesn't change. If we multiply that, Anissa, I'm recording a lecture. If we multiply that then by our 40 breaths per minute, we're then going to get 6,000 mLs per minute. If we go to our alveolar ventilation, 6,000 minus 6,000 equals 0 mLs per minute. Okay, so you can see here, if you take these very short, shallow breaths, overall what you're going to get is you're going to get no air reaching that exchange surface. I'm going to show a video in the very beginning of next lecture that's going to be able to show you what happens when you take a lot of short, shallow breaths. Okay, so we've talked about how air gets in through the ideal gas law. Okay, we're reducing the pressure inside. We've also talked about how our breathing rate can influence the amount of air that reaches the alveoli. Let's move on to one last section for today overall. We're going to graph some data. And what we're talking about now is how tidal volume and breathing frequency can influence our overall pulmonary ventilation. In response to exercise, we know that when we exercise, we need to get more air to our lungs and then more oxygen to our muscles. But how do we do that? There's different dynamics. And I want you to think about the last time you went out for a run and you started out nice and slow and we're kind of moving slowly at the very beginning of this, not working too hard. Were you breathing very fast? Probably not. Were you breathing a little bit deeper? Yeah. So let's graph both of these and figure out how it works. Tidal volume we're going to do in blue. And that's on this y-axis right over here. So we'll start at exercise intensity of 0. And at exercise intensity 0, we're at 0.5 liters per breath, 500 mLs, just like we just talked about. Okay? Breathing frequency, we'll get to in a minute. As we move to 25% of our exercise capacity, we are at 1. Then when we get to about 50%, we're at 1.7. Then when we're at 75%, we're at 1.9. And then when we're at 100%, we're going to be at 2. So if we draw a nice line here, it would look just like that. Now, let's go to the other side. What happens with breathing frequency? Remember, I just mentioned, okay, in the beginning stages of exercise, is your breathing frequency going to change that much? Well, probably not that much. So let's start at our 0, and now we're over on this axis over here. At 0%, we're at 12. Here's 10. Here's probably our 12 right there. So we're going to start kind of right there, okay? When we move to 25%, we're going to move to 13 breaths per minute. So we're not going up very much. We're probably about there now. And then we're at 50%. We're going to be at 15 breaths per minute. Still not much change. If we go to 75%, now we're seeing a change, 25%. And then when we get to 100%, we're at 45 breaths per minute. Whoa. So if you follow this line right along there, there we go. The main point about this that I want to make is that in the early stages of exercise, when you first start exercising, what's going to happen is in order to, meet the demand for increased gas exchange, your pulmonary ventilation needs to go up, okay? And your pulmonary ventilation is met through increased tidal volume in the beginning stages of exercise. When you start and you move from a sitting position to an easy walk or maybe even an easy jog, you're not breathing very fast, but your breaths are going to be a little bit deeper overall. But on the other side, when you are finishing a 5K, running as fast as you can, your breathing frequency is very, very high, okay? But also, you can see that your tidal volume is high as well. So we're going to get a really, really large overall pulmonary ventilation, okay? The example we gave before, we didn't change pulmonary ventilation. In this example that we're giving here below, yeah, we're at 40 breaths per minute, but guess what? This tidal volume is also all the way up at 2 liters per breath. So you know that our pulmonary ventilation is going to be way bigger than 6,000 mLs. Okay, it's going to be closer to 40,000 mLs. Okay, so if we want to finish this with this last example right here, what does this figure teach us about how ventilation is increased during progressive exercise? Well, let's move to a smaller figure. In early exercise, increased tidal volume, right, equals increased pulmonary ventilation, which equals increased oxygen uptake. Because remember, if we're exercising, we need more oxygen. We need more oxygen uptake. In late stage exercise, increased, not tidal volume, this is when our breathing frequency, that's going to be the main driver of our increased pulmonary ventilation in late stage equal, and that's going to equal our increased oxygen uptake. I don't know why that's there. There we go. Equals increased oxygen uptake. So there you have it. Overall, we know that when we start exercising, the thing that's going to drive that is going to be our tidal volume. And when we're getting closer towards the end of exercise, where we're working as hard as we can, we're sprinting it out at the end, that's when your breathing frequency is going to be high, very high. These two factors working together are where they're going to influence our oxygen uptake overall, and then we're going to see about how that changes our gas exchange, because that's where the rubber really meets the road as far as what we're concerned with. Right now, we're just talking about getting as much air into our lungs, and especially to our alveoli, because that's where that gas exchange is going to take place. As we move forward through this lecture and through this unit, we're going to be talking about how that influence of increased oxygen uptake will then result in increased oxygen transport. Okay, stay tuned for Monday's lecture. We'll have some grades posted by then for exam 2. If you have questions in the meantime about this lecture, about any of the questions I went over, make sure to email me. I'll be posting an update at that time.